Welcome to the Latte Lounge podcast. Join me, your host, Katie Taylor, as we talk balancing hormones, busting myths, breaking taboos, boosting libidos, and bolstering confidence. This series is brought to you in partnership with the Latte Lounge Plus, the new online menopause clinic where you can get online appointments with an experienced menopause doctor, a personalised treatment plan to manage symptoms and prescriptions, if right for you, delivered to your door, all for just £45 a month, and that includes prescriptions too. So check out the show notes for more details on how to get your appointment booked in. If there's any symptom that can make you feel old before your time, it's the dreaded joint pain. Our Facebook group is full of discussion about stiffness, aches, and joint pains. Whether that's a creaky back in the morning, sore knees, aching hips, painful elbows, and so much more. In this week's episode, I'm speaking to leading rheumatologist Professor Hasan Tahir about just why we experience all this as we age and what menopause has to do with it. We're going to discuss everything from common aches and pains right through to conditions such as degenerative disc disease, osteopenia, and osteoporosis and fibromyalgia. I want to use this episode to help you understand more about how you can get the right diagnosis for you, plus the range of treatment options, including standard pain relief and lifestyle measures, and when to know when it's time to seek more specialist help. So I'm delighted to be able to speak today to Professor Hasan Tahir, who is a leading rheumatologist. Professor Tahir is an award-winning specialist in rheumatology, sports medicine, and general medicine. He's a consultant at the Royal Free London NHS Trust with several private clinics and is actively involved in the latest research and the use of new treatments in arthritis. He's been a TV presenter of a live health show and is actively involved in humanitarian work overseas. Welcome, Professor Tahir, and thank you so much for joining me today.
Thank you for inviting me to your podcast show.
Now, listen, I thought what would be really helpful is perhaps if you could start by explaining a little bit about what happens to our joints and muscles as we age.
Okay, good question. So the way I'd like to divide it up is we look at a musculoskeletal system. So that involves bones, joints, and muscles. So if you look at bones, which probably most of us will be familiar with what happens as we get older. We know that as we get older, you lose bone mass or density, and that's more common in women after they have got, or once they've got to their menopause. That's what we describe the term osteoporosis or osteopenia, so the thinning of the bones. What's also really interesting is that we all see that as we get older, we sort of shrink a bit. And what we find here is that as we get older, you have these vertebrae, and in between the vertebrae, you have these like gel-like cushions called discs, and they sort of get dehydrated, and that probably starts making you shrink a bit as well. So as we get older, we see that in the bones, and we also see as we get older that our spinal column we sort of become curved to a degree as well. You probably notice that as we get older, we get a bit shorter, not only from that process, but our foot arches also become less pronounced, and that also reduces height to a degree. So that's bones. Joints, again, as we get older, we become a bit more stiffer in our joints, and they're less flexible. So I'm sure most of us will note that per decade as you get older. The fluid in the joints may sort of decrease. Cartilage starts to rub together. You hear of this terminology of wear and tear, especially involving weight-bearing joints or joints that we use a lot. So knees, hips, the thumb joints. So you see that in the joints as well. And with muscle, overall, you find that your lean mass actually decreases. And that's because what you tend to find is you get loss of muscle tissue as we get older. Muscle fibers may sort of shrink and then become just less flexible, more rigid, and they may lose their tone. Even if you exercise, even though I still encourage people to exercise, especially as we get older as well. And the speed at which these muscle changes occur possibly are genetic, but we tend to find this occurs actually interestingly much earlier in men than it does in women. And you tend to find in women, this occurs around the age of about 40, 50 years of age.
Yeah.
Helps.
I mean, it's interesting you say around 40, 50. I mean, I was going to ask you that why are there so many sort of midlife women susceptible to pain and injury at this age? I mean, what I was, I guess, getting at is it inevitable? And what does menopause have to do with why this is happening?
Fine. Good question. Probably won't be able to definitively answer it. Clearly, you're absolutely right. As we get to the menopause, as women get to the menopause or perimenopausal, one of the most notable things are hormonal changes. And one of the key hormones that changes, the estrogen levels drop in women. And what we know is that this lack of estrogen, it has an effect on a multitude of musculoskeletal aspects. So it affects the bones, it can affect the muscles, tendons, and it can affect the cartilage. So whether that is related can't be definitive. It's not definitive, but certainly the opinion is that that probably plays a key role. And we also know that people who have lower estrogen tend to get more joint pains as well, because you tend to find estrogen receptors present in a lot of the joint tissues. So possibly that's the reason why you tend to see it, especially in women around that age group.
Yeah, sure. Now, you're a rheumatologist, and I'm sure you see a lot of midlife women, women over 40 in particular, in your clinic. Maybe before I sort of dig a bit deeper into some of the conditions, what does a rheumatologist actually do? What do you specialize in? And then maybe you can sort of tell us a little bit about the sort of most common complaints you hear from us.
No, sure. So first of all, you'll probably know, as doctors, we're divided to physicians and surgeons. So a lot of people have heard of orthopedics, who are surgeons who do a lot of cutting, whereas we are physicians as rheumatologists, and we do deal with musculoskeletal conditions affecting any part of the body. Not only do we deal with musculoskeletal conditions, we also deal a lot with autoimmune conditions and inflammatory conditions in all age groups. So this misconception that arthritis, for example, is a condition of the elderly or the middle age is not true. It affects a lot of young people. And so it actually affects the whole age spectrum. And this is something that we look after. So examples of conditions that we look after. So you will hear the term inflammatory disorders affecting joints, such as rheumatoid. There are conditions such as psoriatic arthritis and axial spondyloarthritis. These are just names of arthritis over and above what you would have heard commonly, such as osteoarthritis. We deal with a lot of autoimmune conditions. So you'd have heard of conditions such as SLE or lupus, myositis, Sjögren's, vasculitis, those sort of conditions as well. And clearly non-inflammatory conditions, for example, fibromyalgia as well. So it's a whole array of conditions, basically anything that affects the joints in a nutshell, and most autoimmune conditions that potentially affect the musculoskeletal system.
Yeah. Now, you touched on fibromyalgia, and I'm glad you did, because we hear from so many women in our community who are diagnosed with this condition. And often the symptoms they describe to us are very similar to the perimenopause and menopause symptoms. They can possibly run alongside them as well. And it's quite hard for these women. The emails I get are so upsetting, because they're being they're going around in circles, they're being passed from pillar to post, and they're getting, very different diagnoses and different I suppose, treatment discussions around how to relieve that pain they're living with. So, first of all, could you explain what fibromyalgia is, and then how do you diagnose and treat it and figure out, what's going on, whether it's menopause or both?
Yeah, I mean, that's a really, really good question. It's a very challenging question. And I think as menopause is coming in the open more and more, certainly in the last few years, these questions are being raised. Unfortunately, I don't think anyone is going to give you a straight answer as to discriminate between the two. But let's go back to, say, you asked the question, what is fibromyalgia? Starting from that, fibromyalgia, it's really nicely defined. If any of your listeners go onto the Versus Arthritis site, They talk about it being a long-term condition, so something that you've had for at least more than 3 months, but a lot of our patients have it for many, many years at times, that causes pain and tenderness all over the body. It's not an arthritis. That's the important thing. But you do have problems with your joints, bones, or muscles, but it's not an arthritis. And we don't really know why people get it. We don't know the etiology or the cause of it, but it's thought possibly, depending on which theories that you look at, caused by the nervous system in the brain and spine not being able to control or process pain signals from other parts of the body. So what you tend to find is it tends to affect women, more common, like a lot of musculoskeletal conditions tend to affect women more than they do men. Again, classic symptoms are generally widespread pain, not just I've got pain in my wrist or pain in my, let's say, knee. It's in most parts of the body. It's associated with tiredness and disturbed or poor sleep. Again, classic symptoms in patients who are perimenopausal or menopausal. You could also get cognitive dysfunction, brain fog. Again, these are sort of similar symptoms that one can see in perimenopausal, menopausal patients as well. So there is a whole overlap. So the question is, how then do you discriminate? I mean, the most important thing is that the symptoms I've sort of relayed, you do see in other conditions. So one of the most important things is when we consider fibromyalgia, we should be looking at excluding potentially other conditions. So none of the conditions I mentioned a bit earlier, such as inflammatory diseases, and other conditions that can cause tiredness, for example, checking people's thyroid, cortisol levels, making sure they don't have vitamin deficiencies like B12 or folic acid deficiencies, for example. They don't have celiac disease. A lot of the conditions that can mimic some of the symptoms that I've mentioned. So as I said, it is usually, we try and look for other conditions as well. Something we've probably hands up not been great at is saying, well, could this all be related to perimenopause or the menopause? And how are we going to tell? How can you tell? Let's say we've done all the investigations, which in main usually tend to be bloods, maybe imaging in some people, just to, if we're worried about certain areas. And let's hypothetically say they are all entirely normal. Then and you've got then you've got to ask yourself, okay, is this perimenopausal related, menopausal related, or is it fibromyalgia? One of the things is very helpful to look at is, do they have, for example, on examination, tender points? But that's not necessarily a hard and fast rule. You tend not to see that a lot in patients with perimenopause, menopause, but as I said, it's not a hard and fast rule. Also look at how long they've had symptoms for. Some people genuinely may have had symptoms for 10, 15 years, since the age of 30, 35, way before they're perimenopausal, menopausal. And that will say, well, possibly this is more likely to be fibromyalgia. And maybe that their perimenopause, menopause have made matters slightly worse. So you're looking at clues. And if you really are suspecting that this could still be perimenopausal and menopausal, there's an argument to potentially give a challenge with HRT. So we will normally ask the GP, because revert back to GP, say, would you like to give a trial of HRT to see if there is any difference? Does it actually help the symptoms? The interesting thing with HRT, if you look at studies, they haven't really shown from an evidence-based perspective that they help with joint pains. But if you look at it from asking patients, that some do notice an improvement. So as I said, you can see it's not very clear cut. People talk about diagnostic criteria as well. If you have to have these tender points, you have to have this, you have to have that. I would just give caution there, because remember, diagnostic criteria in medicine, certainly in rheumatology, are not really there for clinical diagnoses. They're actually there for research purposes, to identify clean patients. You have this, and therefore you'll come into a research trial. And what the risk is that we'll say, oh, but I don't have this and this and this and this, so therefore I can't have fibromyalgia. And that's actually not true, or any condition. So we have to have caution when we look at diagnostic criteria and what the purposes of those diagnostic criteria are. So I hope that makes sense. I mean, as I said, yes, there is definitely an overlap. unfortunately, it's not simple. And I think you have to make a clinical judgment when you make that decision.
Yeah, it's a bit of detective work. I mean, I know myself, I've been to see rheumatologists over the year with backache and joint ache, and you know, it took a long time. And actually, for me personally, HRT was the answer. For other women, you know it hasn't helped at all. So so let's say you've possibly, you know, got to the bottom of it and you've decided on treatment options. I mean, what sort of medical treatments are there for things like pain relief, short and long term? Because I think there is nothing worse than living in pain. You know, and what can we do? And maybe we can also just have a little chat about lifestyle options as well.
Yeah, so again, really good question. I mean, what we have to understand is everyone perceives pain in a very different way. And when someone comes to me, say, with a chronic pain condition or fibromyalgia, the key is setting expectations and trying to make people understand what we're trying to achieve. Unfortunately, the goals aren't eradication of pain. And so therefore, by setting expectations and understanding, that helps. So I just always think, generally going back to any long-term condition, patients understanding their condition generally help long-term, and that will be helping with their pain, part of their pain management. So education of the underlying condition is fundamental. Fibromyalgia is not like the standard, you know, let's say, for example, you knock yourself on a table and you get that acute pain and you sort of put a bit of ice on it, take some paracetamol, anti-inflammatories. It's not like that. And when you've done that, it gets better. I think you have to approach it in a very different way. It's fine. You can take what I call those short-term pain relief, things like paracetamol, things like codeine, things like anti-inflammatories. Even tramadol. These work short-term and give you short-term pain relief, but that I don't think is the long-term solution. I'm going to come back to medicines in a minute. The other things that which are really important for generally pain management would be things like exercise, and usually in a supervised manner. Because a lot of the pain, you know, you get tight muscles, you get stiffness. And stretching, strengthening, supervised aerobic exercises have been shown to be of benefit. We also know from general chronic pain management, some psychological support. And what I mean by that is seeing a psychologist who can help with therapies such as mindfulness. There's cognitive behavioral therapies. And there's an array of other things like relaxation therapies, Tai Chi, all been known to help with pain management. And I'm going to come back to then medication again. Like I mentioned, short-term pain relief. Then you've got your pain modulators, such as amitriptyline, drugs such as duloxetine and pregabalin, for example. These sort of come under the umbrella of antidepressants and anticonvulsants. That's not because you have depression or you have epilepsy. These drugs have been shown to be beneficial in patients with pain management. So as you can see, there's a whole array of things that are used to help patients manage their pain. So reverting back to the understanding of their condition, setting expectations, engaging with exercise, which usually supervised fashion, engaging with psychological support, and the pain medication. I think the real takeaway here is that your treatment is not just a tablet. It's a number of those, what I call multimodal, multidisciplinary treatments.
And I guess, you know, we've talked about lifestyle. Now, I do want to go back to that in a minute, but when is surgery recommended? Because often people are in such crippling pains. I mean, I heard from a lady this week who has arthritis of the neck, and it's so bad. And I think what's happened is her discs have completely worn away, and they call it wear and tear, but it's obviously a lot more than that. Would you say surgery for conditions like that is a very sort of last resort?
So I think we've got to be careful here. So fibromyalgia per se, you shouldn't really have the fibromyalgia per se in its own right doesn't cause any structural damage, hence the need for surgery. Remember, as we get older, we can get a number of other conditions. We mentioned with age, you can get degenerative arthritis. And what you're talking about, for example, in the neck, the wear and tear. And what you tend to find is that patients who have conditions such as osteoarthritis or any type of arthritis, and they can have secondary pain syndromes such as fibromyalgia, you tend to find that the pains tend to be slightly more exaggerated, i.e. worse for those individuals. And therefore, you tend to find that you have to revert to other treatments. So the fibromyalgia, no surgery, but if you have another underlying problem, as long as you've gone through the various different treatments for that, and you're failing those treatments, it's not unreasonable. So example, knees. So you may have osteoarthritis of the knees. You would do exactly the same thing as you would do if you didn't have fibromyalgia, go through the processes of medical treatment, physical therapies, possible injections. And if that doesn't help, then you would consider an opinion from a surgeon to see if that will benefit that individual person. You
actually mentioned there about injections, so steroid injections. Is that helpful for pain? I mean, we hear a lot of women who are scared of it in the group because they've been told it can really damage the muscles.
So again, the problem with musculoskeletal conditions, they are so varied, and it all depends on what you're treating, and it's not one size fits all. And that's important. So injections are given for various reasons. So I'd get in my clinic, someone say, well, I know someone who had an injection for a muscular problem, and we're talking about an arthritis. And you're comparing apples with pears, for example, there. So you have to talk to your treating doctor about what they're doing, what the steroid would do, what they're actually ultimately how it will benefit them. I do believe that steroids do help a lot of conditions potentially, and again, it depends what that condition is which are so varied. But steroids per se, injection or per se, is not the treatment for anything. It's a part of treatment. So, for example, knee, we were talking about knee just a while ago. If you were to give an injection to the knee, you'd also look at other factors like physiotherapy, weight loss, for example, if you are overweight, as helping longer term in the management of that particular condition.
Yeah, and you touched on weight loss, and I was going to actually ask you that, we've talked about the inevitability of wear and tear as we get older, and some women may have had maybe haven't optimized their diet or exercise because we're very busy, we're juggling a lot of things. And so what can we all be doing now to prevent hopefully further injury and pain in the future, and protect our long-term health for as long as possible?
I mean, so these are your lifestyle changes or addressing your lifestyle. So logic will say that limit your weight. I mean, try to eat healthy, try to engage with exercise, try to incorporate whatever you do in what you do day to day. I mean, that is really, really important. There is a whole array of things that can be done over and above, say, weight loss. When we talk about exercise, people say, "Oh, we find that difficult to do." What do you mean by exercise? Even if it means simple walking, what we try to do is say, can that be incorporated into your day-to-day? So, for example, if you drive to work, maybe park the car further away, come out and then do a brisk walk. That can be part of your exercise, as an example. I think we should also look at your diet as well, and the type of food we eat. And the general encouragement is good nutrition is fundamental. The right type of food, food ideally is not that will give you calories and gain weight, as an example. So all of these things technically are beneficial.
Yeah. And I think before I let you go, one last question, which we hear from a lot of our menopause specialists who say that for those who can and want to take HRT, it can prevent osteoporosis, which is fantastic news. In your opinion, I know obviously you're not a menopause specialist per se, but in your opinion, is there something to be said that maybe everyone of a certain age should be using it to strengthen their bones, or are there other more natural ways, like for example weight-bearing exercise, where we can strengthen the bones without the need for it?
So look, I wouldn't put people on HRT just for bone strengthening. So a lot of our menopause experts will be putting patients on HRT for various other symptoms that they're getting to help with those symptoms. For bone strengthening, 100% agree with you that engage with things like exercise, weight-bearing exercise, making sure your calcium and vitamin D input, your calcium levels are good, your vitamin D exposure is good, or sunlight exposure and vitamin D levels are up. Though that they are good things to do. I mean, the only caution with HRT is there's always this potential risks that people talked about with heart disease and breast cancer. But and that was following a study, I think, many years back. But a lot of those findings have been sort of refuted in the younger cohort. And again, I'll be guided by our menopause experts with regards to that. But again, just in practice as rheumatologists, it's not something that we would encourage every single patient to be on. We'll look at other things.
Absolutely. And for anyone that's listening, if you listen back to some of our episodes before with a couple of our menopause and breast cancer specialists, you'll hear the full understanding about the report Professor Tahir is talking about, which was the Women's Health Initiative, which has basically been refuted. So before I let you go, where can people find out more about you and go for some help and support should they need?
So sure, you can come in. I have a lot of information about myself on my website. My website is www.myname, which is Hasan, Hasan Tahir, Tahir.com. So if you log into that, it's got a wealth of information for patients about lots of different conditions. And it also tells you about who I am, where I work as well.
And you've got an app, is that right?
I do, and that's it's an app called My Spa. So I've got a big interest in inflammatory back pain, and it's an app basically around a condition called axial spondyloarthritis and psoriatic arthritis as well.
And that's called, is that My Spa educational app?
Yeah.
Yeah. We will put all this information in the show notes so people don't have to worry so much. Well, look, thank you so much for joining me today. I know there are so many different conditions we could have gone into a deep dive on, but I just hope this has really helped everyone with a sort of top level about pain and sort of, rheumatological conditions and concerns. And as ever, please obviously do speak to your own healthcare professionals if you're worried. So thank you very much again for listening, and thank you, Professor Tahir, for joining me.
Thank you, Katie.
This podcast is brought to you in partnership with the Lassie Lounge Plus, the online menopause clinic. With thanks to our podcast producer, Emily Crosby Media.